Hello, everyone. Our topic today is about integrating palliative care practices in intensive care units. A very important topic that's undertaught probably in medical schools. Objectives of the presentation. Background. Palliative care is a holistic approach which incorporates management of physical, psychological, and spiritual symptoms. Communication regarding goals of care, support for clinicians and families, and planning for care transitions in patients with critical illness. Even though data suggests that palliative care improves quality of life and decreases caregiver burden, cost on hospital and intensive care unit length of stay, the integration of palliative care in the ICU is not universally accepted. Poor understanding of what palliative care is one of the barriers to the widespread implementation of their services in ICU. So this is basically the purpose of this presentation, is to know more about palliative care and how to integrate palliative care in the intensive care unit. First, I'll give you a quick idea about different types of ICUs. We have different models. We have the traditional, we have ones that are divided by the organ system, ones that are divided by clinical syndrome, and those by basically by the client itself or clientele. Whether this is like neonatal, ped, or gynae, clinical syndrome such as burn, trauma, stroke, cardiac, neurorenal, this is the organ system, and so forth. Traditional specialties like surgical, medical, and so forth. WHO organization has defined palliative care as providing relief from pain and other distressing symptoms, affirming life and regarding dying as a normal process, intending neither to hasten nor postpone death, integrating the psychological and spiritual aspects of patient care, offering a support system to help patients live as actively as possible until death, offering a support system to help the family cope during the patient's illness and in their own bereavement. So, what are the benefits of palliative and supportive care? Well, palliative and supportive care provides treatment to patients with serious illness. It helps with the quality of life, depression, emotional problems, survival, rehabilitation, recovery, social and spiritual problems. Palliative versus non-palliative. So generally speaking, things on the left here are basically palliative in nature, and things on the right are not palliative, such as, for example, non-palliative measures, such as aggressive measures, such CPR, mechanical ventilation, dialysis. These are kind of things, TPN, all of these are considered basically non-palliative. And then you have in the middle, there are variable issues here, such as blood transfusions, treating different types of infections, and tube feeding. According to Harrison here, these are the commonest symptoms in terminal illnesses. Basically fatigue, pain, delirium, dyspnea, nausea, depression, and insomnia. We'll start with pain or total pain. So we know that pain is not only physical, it's also spiritual, emotional, and social. This is what we call total pain. This term was coined by Cicely Saunders in the 70s. Um, this methodology here, uh, the critical care pain observation tool, or CPOT, is one way to assess pain in ICU setting. And it's very similar to, the dementia, as similar to the FLAC, all of these nonverbal, assessment tools. I mean, somewhat. I mean, there's some modifications, of course. So we see here the facial description, body movements, muscle tension, compliance with the ventilator. This is something that's not in other, scales. And then vocalization in extubated patients. So, so this is the method of choice for patients in the critical care to assess pain. As far as medications, in the ICU, in fact, it's much simpler than you think it is. We have mainly three medications that we use. Okay, morphine, fentanyl, and ketamine. Sometimes they replace morphine with hydromorphone. That's about it. Okay, especially in patients with kidney impairment, morphine is not really preferable. But basically, these are the medications that we use in the ICU for pain control. Uh, Morphine is contraindicated in patients with GFR less than 30 ml per hour. Fentanyl is a drug of choice in renal failure. Ketamine is not an opioid. It works on the NMDA receptor, and it basically blocks this central sensitization process. We use it as an adjunct in the ICU to reduce the amount of opioids. So, what is the problem of using morphine? The problem is if you don't watch your renal functions, the morphine metabolites, the M6G and M3G, can accumulate. As you see in this picture here, the M6G is super analgesic and M3G is excitatory. So you get a picture of a mixed delirium. You'll see a patient that is comatose from the M6G and having myoclonus from M3G. Opioid neurotoxicity is a spectrum, guys. Okay, and I want you to visualize this picture here in your mind, because this is basically what happens if you overdose with opioids or you develop renal failure in the context of an ICU patient here, and you accumulating metabolites in your body. So if you see the opioid, the spectrum starts with opioid tolerance, and then goes into myoclonus, and then ends with seizures. Okay. Uh, Also, in the middle here, opioids can induce delirium and agitation that misinterpreted as pain. Also, opioid can cause what we call opioid-induced hyperalgesia. All of this is under the umbrella of the opioid-induced neurotoxicity. Okay, so what are other adjuncts to pain control in ICU? We actually like to use regional techniques and anesthetic techniques in some of these patients. And basically, regional techniques are central or peripheral. Central, like epidural injections, for example. These are central. Okay. Peripheral is like peripheral nerve blocks. So there is a trend nowadays is to shift from central to peripheral. While central give you the best quality of pain control, but the peripheral definitely has less side effects and complications. And in fact, you can use it even in anticoagulated patients, okay, and patients that have spinal cord compromise. So this is a thoracic epidural, for example, patient that had, for example, let us say, pneumonectomy or pulmonary surgery, for example, or upper abdominal surgery. So thoracic epidural would be a good choice, but again, there is a risk of complications of like epidural hematoma, all of this stuff, or compromising the spinal cord. So it's higher risk, but better quality, definitely. It's the gold standard, okay? And it does help patients that having thoracoabdominal surgery uh, being protected against, DVT, ileus. It really is very important for these patients. Nowadays, we try to go more peripheral and use other peripheral blocks that will be more safer, such as erector spinae plane block, okay, or serratus anterior plane block. And we have other host of new peripheral blocks that available right now. But I just wanted you to give you the idea is we're going from central to peripheral. Okay, we'll start another topic here is the total breathlessness or dyspnea, because this is a common finding in ICU folks. Now, we know for sure now that dyspnea is like pain. It is a total dyspnea or breathlessness. Okay, it's physical and non-physical, emotional, social, spiritual. The better terminology is breathlessness, okay? Because this is more like, scientific type of name. Breathlessness is more like a layman language, so it's easier to communicate with patients. What is definition of dyspnea? Dyspnea is defined by the American Thoracic Society as a subjective experience. I mean, remember, pain is also subjective, right? Subjective experience of breathing discomfort that consists of qualitatively distinct sensations that vary in intensity. The experience derives from interactions among multiple physiological, psychological, social, and environmental factors. This is the non physical part, right? The total dyspnea, total breathlessness, similar to total pain. All right. Uh, we have different types of dyspnea or breathlessness. We have a breakthrough and we have continuous. Okay. We have refractory dyspnea, which is a debilitating symptom of advanced pulmonary and cardiovascular disease characterized by difficulty breathing, persisting at rest, or with minimal exertion, despite optimal therapy of underlying condition. And lastly, we have another type called the dyspnea crisis, which is defined as a sustained, like pain crisis, right? We have dyspnea crisis, sustained and severe resting breathing discomfort that occurs in patients with advanced, often life-limiting illness and overwhelms patient and caregivers' ability to achieve symptom relief. These definitions are unfortunately are very important to remember here and memorize. I mean, you need for communication purposes and for treatment. Now, the dyspnea is managed similar to the WHO guidelines for pain. We have three steps, okay? First step, try to optimize your bronchodilators, exercise training, supplemental oxygen according to COPD guidelines. Uh, then step two is non-pharmacological measures such as pulmonary rehab, pursed lip breathing, fan, relaxation, paced activities. And a third step will be opioids, okay, with or without anxiolytics. Delirium is something we see a lot in at end of life and in the ICU. And we have three types of delirium. We have hyperactive, hypo, and a mixed delirium. And a delirium is an acute onset and fluctuating. Fluctuating is the key word here in delirium. It has to be fluctuating, otherwise, it's not delirium. Fluctuating course of disturbance in attention, level of arousal, and other aspects of mental status. These are the delirium risk factors: age, social isolation, polypharmacy, perioperatively, severity, a bit like burns, HIV, organ insufficiency. So these are important risk factors to look for delirium. The way we assess delirium is through a method called the Confusion Assessment Method for the ICU, or CAM ICU flow sheet. And it goes very smoothly from one step to another, and starting with acute change or fluctuating course, and then, if yes, inattention, altered level of consciousness using the RAS level, disorganized thinking. So it goes into four steps here to identify a delirium. The RAS scale is a very important scale um, for agitation and sedation in the ICU. Richmond Agitation and Sedation Scale. Okay. Basically, 0 is alert and calm. As you go up, you're getting more restless and agitated, and more like 4 is combative. Going down, you're getting more drowsy and sedated until you reach level 5, -5, which is unarousable. So, what are the sedation that we use in ICU? These are the three commonest methods used: midazolam, propofol, and dextrometamidine. Midazolam is a benzodiazepine that works on GABA A receptors, and it's one of the most widely distributed drug in the ICU. We give it as an infusion. Propofol is another method. Uh, Propofol is made in soya bean emulsion. So this can cause hypertriglyceridemia. Also, it can cause, it can get infected and so forth. And it can cause something called propofol infusion syndrome. And then dextrometamidine is an alpha 2 agonist, similar to clonidine. And this is you know, the new one in town, basically, and it's used for sedation that is not, uh, you know, uh, well done through the midazolam or propofol. So it does help with agitation. It does help with pain, and patients can be kind of, more communicative than the other midazolam and propofol. The main problem with doxymetamidine, it can cause some hypotension and bradycardia, and also it doesn't cause amnesia. Like midazolam and propofol are amnestic agents because they work on the GABA receptors, so they have an amnesia effect. But dextrometamidine works on the alpha 2 receptors in the brain that releases adrenaline, in your brain, noradrenaline and adrenaline in your brain. So it's different. One of the syndromes I just wanted to raise your attention about is called propofol related infusion syndrome. And this happens when you're giving propofol in high dose, more than 5 per kilo per hour for more than 48 hours. And this can result in abrupt onset of profound bradycardia metabolic acidosis, renal failure. Um, so risk factors are poor oxygen delivery and sepsis. Bereavement. This is an important topic in ICU and end of life patients. Five stages of grief, as you know, by Elizabeth Kobler, is the denial, anger, bargaining, depression, and acceptance. These are basically classic, in medicine right now. Despite that, we know now that it doesn't have to go this stepwise fashion here. I mean, depression can come before bargaining and so forth. Grief, mourning, and bereavement. Grief is our personal experience of loss. Mourning is the public expression of our grief. And bereavement is a period in which a loss is a period after a loss during which mourning occurs and grief is experienced. This is a very nice definition for these three, conditions here. I know there are other definitions in the literature, but I chose this one because it makes more sense to me than any other definitions here. So, what are the risk factors for what we call complex bereavement disorder, which is basically bereavement beyond 12 months for adults, 6 months for children? Uh, who's the person who died? Okay, if it's a loss of child, this can cause persistent complex bereavement disorder. The nature of the attachment, the mode of death, if it's unexpected, whether it's a violent or criminal or whatever, a history of mental illness or poor coping, lack of social support, multiple prior loss. All of these are risk factors for persistent complex bereavement disorder, PCBD. And PCBD, according to the DSM-5, is basically an individual that experienced death of someone with whom or he had a close relationship. And since the death, at least one of the following symptoms is experienced. For at least 12 months after death in adults and 6 months for children. And these are the symptoms like persistent yearning and longing for the deceased, intense sorrow and emotional pain, preoccupation with the deceased, preoccupation with circumstances of death. Sleep disorders. I used to get consultations in the ICU all the time, whether for pain or palliative care. And I learned one lesson that you have to ask the patient about sleep. Okay? Most of these patients in the ICU, they don't sleep. And this will actually cause them to have problems such as, pain and other symptoms like they get agitated and so forth. Anyway, the American Academy of Sleep Medicine has classified, sleep disorders into six major categories. The most important for us is the insomnia and sleep-related breathing disorders. So you see them here: insomnia, narcolepsy, hypersomnolence, breathing-related sleep disorders like obstructive sleep apnea, for example, and others. Restless leg syndrome is also an important topic that you need to know as a pain and a palliative doctor here. Insufficient sleep can cause distractibility, poor attention span, poor organization skills, poor motivation, irritability, easily get frustrated, depression, anxiety, and defiance. Okay, prognostication in ICU. Prognostication, by definition, is a prediction of possible future outcomes of a treatment or a disease course based on medical knowledge and experience. Components are foreseeing, which is estimating prognosis, and foretelling, discussing the prognosis. Medical physicians in general are more optimistic than palliative care as far as prognosis and less accurate. Widely used ICU prognostic models, Glasgow Coma Scale. All of you guys, Glasgow Coma Scale, you studied it in medical school. And then we have the Acute Physiologic and Chronic Health Evaluation, Apache. Simplified Acute Physiology Score, SAPS. Sequential Organ Failure Assessment Score. This is for sepsis. And a modification from this one called the Quick Sequential Organ Failure Assessment Score. And then we have the Provent or Prognosis for Prolonged Ventilation and the Shock Index for hypovolemic shock and 28-day mortality. So Apache, SAPS, and SOFA are very widely used. The Apache is based on the worst values in the first day one, while SAPS is calculated based on data within 1 hour from ICU admission. The Apache is from 1 to 71, with 85% mortality rate if above 34, while the SAPS from 1 to 163 with a 90% mortality if it's above 77. As far as the SOFA scale, 95% mortality rate if it's above 11. And it's basically from 0 to 24. This is the Glasgow Coma Scale. I mean, all of you guys are oriented with it. Apache, okay, these are the physiologic variables. And then you have the age, you have the Glasgow Coma Scale, okay? And we said this one is from 1 to 71. SAPS is from 1 to 163. Okay. As you see, the SAPS is more, comprehensive. That's all. It includes other stuff like type of admission and chronic disease and so forth. And there are many versions of these. I mean, there's Apache 1, 2, and 3, and 4. So, I mean, we don't use it that much in ICUs, except for research. Okay. Sepsis, actually, we can assess it with a SOFA score, okay, which is basically from 1 to 24. There are 6 items: cardiovascular, central nervous system, respiratory, coagulation, liver, and kidney. Each item scores from 0 to 4. And if you're above 11, you have almost like 90% mortality rate. Look at this. Pew SOFA is basically 3 items, and it's a shortened version of the SOFA score. There is a lot of controversy about this one, but it's a simple one. I wanted to teach you how to do it, but it's not very reliable. Okay, shock index. A normal shock index is less than 0.7, and shock index above 1 is predictor of hyperlactatemia and 28-day mortality. So what is shock index? Is heart rate divided by systolic blood pressure. Provent, basically, this depends on age, whether you're currently on vasopressors. I use this one personally all the time in ICU. Very simple, straightforward. So please look it up and try to use it. Okay, and you have here whether hemodialysis or not, the platelet count and vasopressors and the age. Four basically variables here. Okay. So how we relay our message here? We use a spikes protocol. I'm sure all of the palliative physicians know what is spikes protocol. It's a 6-step protocol for relaying the information to the patient's family and to the patient. Okay, developed by Dr. Robert Buckner. Cardiac arrest resulting in CPR in the ICU. I want to say that, the results are not the greatest here. Patients that were spotted to be having cardiac arrest in the ICU, and they were on vasopressors, 9.3% of them survived, while not on vasopressors, 21% survived. Overall, 15.9% survival to hospital discharge. So if you have an arrest inside an ICU, probably you have around 16% chance to go home here. Compassionate extubation, we do it for patients that have futile, prognosis. Okay, I want to say that uh, we don't do this in Egypt, okay, because it's illegal in Egypt. But most countries they sign this DNR status, and thus you can do what we call compassionate or terminal extubation. Okay, which is by definition is withdrawal of mechanical ventilation from critical ill patients. Okay, when we do so, we use some supporting agents such as anticholinergics, benzos, and opioid. I like to use the short-acting drugs actually, like midazolam, fentanyl, and glycopyrrolate. And we call the religious counselor in the hospital to be around, while extubation as well. Uh, Now we're going to talk about three important issues here: DNR and DNI, sedation and physician-assisted suicide and euthanasia. I want to say I color coded these things because DNR and the DNI is basically, approved by most authorities here. And in fact, like in Saudi Arabia, three consultants sign, a document that patient is a DNR. You don't need to ask the surrogate or the family, although you have to communicate with them. Palliative sedation, I like to put it with the yellow because it's like in the traffic light, it's a yellow. It can you can get into slip into then what we don't want actually, a physician assisted and euthanasia here, suicide. So palliative sedation, we use controlled administration of sedative medications to reduce the patient consciousness here. As far as physician assisted suicide, it's not approved by most authorities all over the world. Only very, less than 5% of the palliative physicians do this stuff, and even in the United States, only three states that do this physician-assisted suicide. Euthanasia is you administer your medication by yourself, and this is illegal in the United States. Physician-assisted suicide, you give the drug to the patient with the instructions, and he will administer it by himself. Okay, so we're going to talk about the integration. Okay, we have different models: integrative model, consultative model, and mixed model between palliative care and ICU. Okay, and you have to know some of these ethical principles. I'm sure all of you know all of these four here, basic principles. But the one that you need to know more is double effect, which is usually a combined effect of beneficence and non-maleficence. The beneficial effects of getting opioids is easing pain and suffering of the patient. The maleficent effect is hastening death of the patient through suppression of respiratory system, and it's basically considered ethically acceptable to most palliative authorities. Okay, non-invasive ventilation. I want to end with this one here. We have the CPAP, we have the BiPAP, we have high flow nasal cannula. You should, as a palliative physician, you should know the difference because you try as much as you can not to intubate the patient and put him on the mechanical ventilator. So you want to always try, especially patients that don't have, a good prognosis here. Uh, so you need to know the difference between the CPAP, BiPAP, and the high flow nasal cannula. The CPAP in general is used in respiratory failure type 1, which is the hypoxemic type of failure, and BiPAP in the hypercapnic respiratory failure or type 2 respiratory failure. And high flow is in hypoxemic respiratory failure. And if the patient is intolerant to the CPAP and BiPAP, I want to say high flow nasal cannula is a new method where you deliver like 40 to 60 liters per minute to the patient. It's much more tolerable than CPAP and BiPAP. Okay, and you can even talk while you're getting your therapy here. So this is emerging methodology in palliative care. We're using it nowadays, but still we don't have a lot of research on it. Okay, these are a couple of references that I used in my presentation. One from BMC anesthesiology, and the other one, palliative care in the ICU from the Intensive Care Society. So I want to end my lecture with why we want to integrate palliative in ICU practice. Okay, and this question you might be asked by a colleague, your ICU colleague. First, because palliative care is a patient-centered approach, improves communication, improves symptoms and quality of life. Patients on palliative care experiences less depression. Palliative care help aligning medical decision with goals and values. Palliative care decreases caregiver burden. Palliative care improves family satisfaction. Palliative care reduces cost and lower intensity of care primarily through a reduction in intensive care units, laboratory work, and diagnostic imaging. Palliative care enhances continuity of care, can assist in DNR discussion, can assist in identifying bereavement risk, shortens ICU stay, doesn't affect mortality, and provides the bigger picture for the patient an option of opting out aggressive measures. And this is it, the end of the presentation here. Thank you so much. I don't think we have much time left, so